Hello everyone, today we are going to discuss about the purine salvage deficiencies. So let us discuss now the purine salvage deficiency and the purine metabolism. So what happens from the ribose 5-phosphate, inositol monophosphate is formed. How it is formed I have already discussed in the purine and pyrimidine synthesis. Inositol monophosphate is formed. From the inositol monophosphate, there can be formation of the GMP and AMP, and from the breakdown of the nucleic acid also there is the formation of AMP and GMP. So first let's discuss about the degradation of inositol monophosphate. So now inositol monophosphate is converted into inosine, then inosine is converted to hypoxanthine, and hypoxanthine with the action of enzyme xanthine oxidase is converted to xanthine, and the xanthine is converted to uric acid by the action of xanthine oxidase, and finally the uric acid is excreted or it can be converted to allantoin. On the other hand, the inositol monophosphate is converted into guanosine monophosphate or adenosine monophosphate. So the guanosine monophosphate are the nucleotides. It can be converted into guanosine, which is the nucleoside. Then it is converted to guanine, which is the free base, and the guanine is converted into xanthine, and it is converted to xanthine oxidase, and it is converted to uric acid. Then it is excreted. On the other hand, the adenosine monophosphate, there is a unique pathway where the adenine is converted into adenosine monophosphate, and adenosine monophosphate is converted to adenosine, and with the help of the enzyme adenosine deaminase, it is converted to inosine, and from the inosine it is converted to hypoxanthine, xanthine oxidase, uric acid, and it is excreted. So there is one unique pathway is going on. The guanine and hypoxanthine can again be recycled to inositol monophosphate or guanosine monophosphate by the help of enzyme hypoxanthine guanosine phosphoribosyltransferase transferase, SGPRT. With the help of SGPRT and PRPP, phosphoribosyl pyrophosphate, the guanine and hypoxanthine can be converted to GMP and IMP respectively. So here we have discussed about the metabolism of the purine, how the adenosine monophosphate, IMP and GMP is converted to uric acid. Now there are the certain drugs like allopurinol and febuxostat, which inhibits the enzyme xanthine oxidase, which helps to decrease the production of the uric acid, which is very helpful in the gout that is used, that are allopurinol and febuxostat. And there are three conditions: adenosine deaminase deficiency, Lesch-Nyhan syndrome, and the gout. These three conditions can be encountered in the purine salvage deficiencies. Now what happens in the adenosine deaminase deficiency? That this adenosine deaminase is required for the degradation of adenosine. This decrement of the adenosine. This adenosine deaminase is required for the degradation of the adenosine and deoxyadenosine. So if this enzyme is lacking, then there is increase in DATP. And increase in DATP leads to decrease in ribonucleotide activity. That is, decrease in ribonucleotide reductase activity. So if there is decrease in ribonucleotide reductase activity, then there is decrease in DNA precursor in the cell, then there is decrease in DNA precursor in cell. If there is decrease in DNA precursor in cell, then there is decrease in lymphocyte. There is decrease in lymphocyte. So the condition is called SCID. The SCID is severe combined immunodeficiency. Here there occurs the T and B cell dysfunction. So the severe combined immunodeficiency. The severe combined immunodeficiency is the autosomal recessive disorder in which there is the deficiency of enzyme adenosine deaminase. If there is deficiency of enzyme adenosine deaminase, then there is increase of DTAP. If there is increase of DTAP, then there is the decrease in action of ribonucleotide reductase activity. Then if there is decrease in action of ribonucleotide reductase activity, then there is decrease in DNA precursor in cell. And if there is decrease in DNA precursor in cell, then there is decrease in lymphocyte. Then if there is decrease in B and T lymphocyte, then there occurs SCID, severe combined immunodeficiency. Severe combined immunodeficiency. So if there is B and T cell dysfunction, then it is severe combined immunodeficiency. So now adenosine deaminase deficiency we have discussed. So now let's talk about Lesch-Nyhan syndrome. So as we already discussed, the SGPRT. The SGPRT is required for the reproduction of hypoxanthine and guanine to inositol monophosphate and guanisine monophosphate respectively. So if the SGPRT enzyme is lacking or there is absence of SGPRT, then there is the more production of the guanine and hypoxanthine. If there is the more availability of guanine and hypoxanthine, then there is more production of the xanthine. And if there is more production of xanthine, then ultimately there will be more production of the uric acid. So there will be hyperuricemia in the Lesch-Nyhan syndrome. So the Lesch-Nyhan syndrome is X-linked recessive disease. Lesch-Nyhan syndrome is X-linked recessive disease. It is defective purine salvage pathway due to absence of SGPRT, which converts hypoxanthine to inositol monophosphate and guanine to guanisine monophosphate. This results in the excess uric acid production. So what is the finding in the Lesch-Nyhan syndrome? The finding in the Lesch-Nyhan syndrome will be there will be intellectual disability in the child, there will be self-mutilation, there is the aggression behavior, there will be the hyperuricemia, which lead to orange sand or red sodium urate crystal in the diaper, there will be gout, there will be dystonia, and there will be microcytosis in the Lesch-Nyhan syndrome. Okay. Now in the Lesch-Nyhan syndrome, the drugs can be given allopurinol or febuxostat as it inhibits xanthine oxidase. Xanthine oxidase inhibits the conversion of xanthine to uric acid, which will lower the production of the uric acid. Now let us discuss about the gout. In the Lesch-Nyhan syndrome also, the gout can occur. So the hyperuricemia may be produced by overproduction of the uric acid or undersecretion of the uric acid by the kidney. So there will be gout can be occurred if there is the overproduction of the uric acid or if there is under excretion of the uric acid. Hyperuricemia may progress to acute and chronic gouty arthritis if uric acid, that is monosodium urate, is deposited in the joints and surrounding soft tissue where it causes inflammation. So the gout is the deposition of monosodium monosodium urate crystal in the joints. So gout is the deposition of the monosodium urate crystal in the joints due to increase in uric acid. So the uric acid is produced from excess endogenous purines and is also produced from dietary purines, that is digestion of the nucleic acid in the intestine or by the intestinal epithelia. Both sources of uric acid are transported in the blood to kidney for the excretion of the uric acid. So in the gout also allopurinol can be used because allopurinol inhibits the xanthine oxidase. So we have discussed about the degradation of inositol monophosphate, adenosine monophosphate and guanosine monophosphate. Ultimately they change into uric acid and they are excreted, or they can be changed to allantoin. And we discuss about adenosine deaminase deficiency that leads to severe combined immunodeficiency, which is B and T cell dysfunction, or there is decreased production of the B lymphocytes and T lymphocytes. And we discussed about Lesch-Nyhan syndrome, where there is very low amount of HGPRT or no HGPRT. And we discussed about the gout, the condition in which hyperuricemia leads to a deposition of the monosodium urate crystal in the joints. Thank you.